స్టార్ట్ చేసేలా కాదు లాగిన్ అనేది ఎలా తెలుస్తుంది మీకు అందరూ ఏం స్టార్ట్ చేసేచ్చు Good afternoon. Today my topic is juvenile idiopathic arthritis, previously known as juvenile rheumatoid arthritis as per American classification. Now it has been changed to juvenile idiopathic arthritis, which means juvenile, I think you might be knowing about juvenile less than 17 years. Idiopathic, no cause. Arthritis means swelling, pain and limitation in the range of movements. So any arthritis which presents before 17 years of age with more than 6 weeks of duration, we can suspect it as juvenile idiopathic or juvenile rheumatoid arthritis. Okay, before I go into this topic, I just want to tell you briefly about what is this juvenile idiopathic arthritis and what are the types, what is the management. Brief introduction I'll give and then I'll start with my topic. Okay, juvenile idiopathic arthritis is nothing but it is arthritis of minimum of one joint or more with 6 weeks of duration, at least 6 weeks of duration, and starting before 16 years of age or 16 or 17 years of age. Okay, the most common cause is it is an interplay of genetic and environmental factors. I mean, some genetically predisposed children whose host tissues are antigenically altered by environmental factors in the form of psychosocial stress, physical trauma, or any viral infections, autoimmune response gets activated and it will attack the subject's or host's own tissues. That will lead to synovial dystrophy, destruction and joint destruction, leading to arthritis. So, as per the definition, it is of more than one joint involvement, one or more than one joint involvement, 6 weeks duration at least, and less than 16 years of age, with autoimmunity as the autoimmune mechanism as the pathophysiology behind this JIA. There are different types of JIA subtypes basing on the number of joints involved and associated systematic features, systematic symptoms, whatever you call. If it is less than less than or equal to 5 joints, it is called oligo or polyarticular, which has good prognosis. If it is more than 5 or equal to or more than 5 joints, if it is more than 5 joints, it is polyarticular, which is again subdivided into rheumatoid factor positive and rheumatoid factor negative arthritis, polyarthritis. Third one is systemic JIA, which is nothing but JIA with systemic symptoms. The other ones are psoriatic arthritis, undifferentiated arthritis, and enthesitis related arthritis. That is the classification. Usually, the presentation of the child will be morning stiffness and gelling phenomena. Gelling phenomena means if a child is inactive for prolonged period or is sitting in a chair for prolonged period, and if he gets up, he'll not be able to move freely. That is called gelling phenomena. So morning stiffness with gelling phenomena and stiffness getting relieved after some time during the day with arthralgia throughout the day. Those are the presenting symptoms of JIA. Here, before I start, what do you difference between arthritis and arthralgia? I just want to tell you brief you about arthritis and differentiate between arthritis and arthralgia. Arthritis is nothing but it's a swelling or effusion of the joint plus tenderness in the joint, limited activity of or limited range of motion with heat around the joint. That is called arthritis. Arthritis means pain, limitation of movements, joint swelling, and heat over the joint. All these features should be, at least 3 features of the 4 should be present, with swelling as a compulsory feature. Arthralgia means it's only pain around the joint. So in juvenile arthritis, arthralgia will be present throughout the day. So treatment will be with NSAIDs or disease-modifying anti-rheumatic drugs, and biological agents will be there, and steroids are also there. In refractory cases, autologous stem cell transplantation. So let us start with the JA. Here we are uh, preparing number of slides will be more, because we don't know whether you are able to follow us or not. If it is a class, we can understand whether you are following us or not. And also some of the slides will be having more lines. We want to make sure that you should not miss even single point while writing, while writing the theory exams. Okay. So let me start with the first slide. As I told you, arthritis is one or more joints with. It is a definition of juvenile idiopathic arthritis, which is nothing but arthritis of one or more joints with onset below the age of 16 years and persisting for at least 6 weeks. It refers to a group of conditions characterized by chronic inflammatory changes of the joints, and it is one of the most common cause of chronic arthritis in children. So criteria, as I told you, age of onset should be less than 6 years, 16 years. Arthritis definition I've already told you: swelling or effusion plus two or more of the following signs like limitation, tenderness, or increased heat in more than one joint. Duration of more than 6 weeks. Onset type defined by the type of articular involvement, like polyarticular if it is more than 5 joints, oligo or polyarticular if it is less than 5 joints. Systemic JAA if it is associated with systemic symptoms, and exclusion of other forms of juvenile arthritis. This is a criteria. Criteria is very important. Definition is very important. So causes. Exact cause of JRA is unknown, but it's an interplay of genetic factors and environmental factors. So as I told you, it's an autoimmune disease wherein the host T and B cells, they fail to differentiate between the self antigens and foreign antigens, and they start one autoimmune response is, and an autoimmune response is mounted against the body's own tissues. Thereby they get attacked by these inflammatory mediators and they get destructed. So the immune system that usually protects our body mistakenly attacks our body's tissues. That is nothing but autoimmunity. In JRA, the host tissue that is commonly affected is the synovium, that is the lining of the joint. The immune system mistakes one of the lining of the joint, that is the synovium, as a foreign invader. Here the synovium, they take it as a foreign antigen because it, this antigenicity of the synovium is altered by the environmental factors which I told is trauma, some infections like that, wherein the synovium gets altered and it will be and it will be shown as presented as foreign antigen to the host immune system. So host immune system, by way of cell mediated immunity, which is by T cells, they at the time attempts to remove it by attacking its cells with biological chemicals are nothing but inflammatory mediators like IL-6, IL-1 beta, TNF alpha, IL-6. All these are called inflammatory mediators or cytokines that cause inflammation. So I just want to repeat once again: the immune system in JRA, the immune system mistakes one of the lining in the joint, that is the synovium, as a foreign invader and attempts to remove it by attacking its cells with the biological chemicals, that is nothing but inflammatory mediators like TNF alpha, IL-6, IL-1 beta, IL-8, like this, that cause inflammations. So there is also T cell mediated damage. The common underlying manifestation is the presence of chronic synovitis. So synovium is the lining of the joint that gets affected in JIA. Risk factors, there are no clear risk factors, but some factors may be associated with some types of JRA that includes girls are more likely to get affected in JRA than boys. Family history of anterior uveitis with eye pain, inflammatory back arthritis like ankylosing spondylitis, inflammatory bowel disease And family history of arthritis or psoriasis in the first degree relative will be the risk factors. Classification as per ILAR is nothing but International League for Association for Rheumatology, where basing on the number of joints involved and the type of onset, they have classified it as oligoarticular, or another word is word is polyarticular, which is subclassified as rheumatoid factor positive polyarticular JAA, rheumatoid factor negative polyarticular JAA, systemic onset JAA, psoriatic arthritis, enthesitis related arthritis. Enthesis is nothing but it is the place of attachment of tendons or ligaments to the joint. So that place gets inflamed. So that is called enthesitis related arthritis. Undifferentiated arthritis means it fits in not in other, it doesn't fit in other categories or fits in more than one category. This classification is very important along with definition. So usual presentation will be, first presentation will be arthritis, which should be present from last 6 weeks for you to diagnose it as JAA. Disease onset may be insidious or abrupt. And history, if you go to the history, they'll present with morning stiffness that improves with time, gelling phenomena, which I told you, that stiffness after long periods of sitting or inactivity, complaints of joint pain or abnormal joint use. So complaints of joint pain will be more in case of polyarticular, and abnormal joint use will be of it will be a common symptom in all it will be a common presentation by smaller children. Older children will be complaining of joint pains as usual, but abnormal joint use will be presented by younger child. They'll not be using that joint, so that is called abnormal joint use. There might be or may not be a history of trauma, but trauma may sometimes precipitate the clinical events. History, so as per history, morning stiffness, gelling phenomena, abnormal joint use, plus number of school absence and limited interest in the physical education classes, 5 along with arthritis should be there. Sometimes there may be spiking fevers occurring once or twice each day. That is called double quotidian fever at some time of the day, at the same time of the day. There may be evanescent rash on the trunk and extremities, these are all extra articular presentations, which you'll be seeing in systemic onset JAM. Psoriasis or some other dermatological manifestations might be there, but psoriasis, if it is present, we should suspect. Psoriasis plus arthritis means it should be psoriatic arthritis. Fevers with rash, hepatosplenomegaly, lymphadenopathy, all these will be seeing in the systemic onset JAA. Some of the variants of the JA are sex and age related. Exception is SJA, which can involve any age. Oligoarticular may present between 2 to 5 years age, and polyarticular will be present in more than 10 years, and enthesitis related arthritis is seen in adults and male or early adulthood. Most in oligo and polyarticular, females are more affected than boys. On examination, the affected joints are usually warm and swollen with reduced range of motion, but not erythematous. Because why I've written not erythematous, because in juvenile idiopathic arthritis, there will not be erythematous. There will not be any erythema over the joints. If there is erythema, we should suspect septic arthritis rather than JIA, which is one of the important differential diagnosis for JIA. Pain with severe erythema will be seen in septic arthritis. Pain without erythema may be seen in rheumatic fevers and JIA. Also, examination of the child with JIA should always include temporomandibular joint and cervical spine. These two also will get infected. So systemic onset JA, which is nothing but still stitches. It accounts for 10 to 20% of cases. With acute onset and prominent systemic features will be there. The systemic features, they usually precede the joint manifestations prior by weeks or months. So first systemic manifestations will be present, followed by arthritis. Sometimes these joint manifestations are overlooked or overcome by the systemic features. It can be polyarticular, mostly involving small and large joints, with onset within the first 6 months of it. Here, I would like to add upon one thing. The type of JAA is determined by the number of joints from onset to the first 6 months of onset. That's an important point. I forgot, but it's a type number of joints plus number of joints involved in the first 6 months of it. 6 months of onset. Okay. So systemic onset, it is a polyarticular type involving small and large joints, and the systemic features include fever, which is high grade intermittent fever for at least 2 weeks of duration with at least 3 consecutive days of fever. There should be 2 weeks of duration for fever with characteristic twice daily peak, that is called double quotidian. More with the fever will be more prominent in the evenings. All these, there is no need to type, but I want to make sure that you should not miss these points while writing your theory exams. That's why I've added all these things. So in fever, you have to remember that minimum of 2 weeks duration should be there. High grade intermittent fever should be there with double spikes in the same day, at the same time, sorry, with the double spikes. These three are important. Rash will be evanescent maculopapular rash, which is transient, non-pruritic, with fading within hours. It is usually seen on trunk, proximal extremities, axilla, and groin. There will be a phenomenon called Copner's phenomenon, where the rash may extend linearly along a scratch mark. If you can see here, there are some lines that is called a scratch mark, wherein the rash gets formed around that scratch mark. It is called Copner's phenomenon. It is also seen in meningitis also. So serosal involvement will be there in the form of pericarditis or pleuritis. There will be hepatosplenomegaly. There will be lymphadenopathy. Here RF and ANA are, RF means rheumatoid factor and ANA are negative. Feltis, just one point on Feltis syndrome, which is nothing but GRA with splenomegaly and leukopenia. So whatever may be the presentation, even though systemic features, they overcome the joint manifestation, but the ultimate end will be the chronic arthritis in systemic onset JA. So while coming to systemic onset JA, we should have, it should be a polyarticular presentation with fever, rash, hepatosplenomegaly, lymphadenopathy, and pleuritis or pericarditis, and the end result will be chronic arthritis. Oligo or polyarticular JA, it is a good prognosis one, and it's the most common presentation of JA with 50 to 60% instance. Here, 5 or few joints are affected. Mostly large joints are affected during the first 6 months of disease. So more common in young girls. Joint involvement is usually asymmetrical. Asymmetrical in the sense, symmetrical means same joints of both limbs. Asymmetrical means different joints or single joint involvement of one side. Two peaks, one will be at 1 to 3 years of age and other will be at 8 to 12 years. Medium to large joints are involved, with knee getting more involved than ankle, followed by elbow and wrist. Joint swelling, this is an important point. Here, the presentation will not be joint pain. Joint swelling will be the more important presentation rather than joint pain, which is quite opposite in case of polyarticular. In polyarticular, joint pain will be the presentation rather than the joint swelling. In oligoarticular or polyarticular, it will be joint swelling rather than joint pain will be the usual complaint. Here RF is negative and ANA will be positive. Smaller joints are not involved. This is as per OPGA. They say that smaller joints are not involved, but if you go to Nelson, If it is a late onset, that is 8 to 12 years of presentation, sometimes small joints and hips also may get involved. So just a brief note, it is a oligoarticular is the most common presentation of JAA, with large joints more involved, with less than 5 joints involvement, and joint swelling will be the usual complaint rather than joint pain. RF and ANA RF may be positive and negative, and ANA may be positive. So in in oligoarticular JA, the subtypes will be persistent and extended. Persistent means if number of joints affected, they continue to be less than 5 in first 6 months of disease, and if the number of joints affected, they exceed 5 after the first 6 months of disease, that is called extended one. So persistent and extended are the two subtypes of OJA. And the important complication of oligoarticular JIA or juvenile idiopathic arthritis, the chronic iridocyclitis. Usually it will be asymptomatic at the earlier, but it is a potentially blinding situation if we don't act on it at the earliest. So we should have regular slit lamp examinations in a female child with oligoarticular presentation and with ANA positive serological test. There should be regular slit lamp examination to rule out iridocyclitis, and the slit lamp examination should be done every 3 to 4 months. Here you can see, here it is written as 4 or fewer joints, but 5. This is a new classification. 5. Early childhood onset is more common, mostly girls, and if it is late childhood, presentation will be over 8 years, and boys will get more affected than girls. But as a whole, girls are more affected in oligoarticular time. If the tests are negative for ANA, there will be no extraarticular manifestation, which is nothing but iridocyclitis. If the tests are positive for NA, we should suspect chronic iridocyclitis will be the important complication, and so every 3 to 4 months we have to go for slit lamp examinations. And in early onset OJA, the joints commonly involved are the larger joints, which I have told, that knees, ankles, hands, wrists, and feet, wherein no hip is involved, where no hip is involved, and if it is a late onset, hip gets involved. But for you just remember, in oligoarticular, only large joints are involved, and the most dreaded complication will be chronic iridocyclitis, and girls are more affected. This is the presentation of iridocyclitis, wherein, if you can see on your left, eyes affected with uveitis are usually red and painful. So unlike conjunctivitis, uveitis causes redness around the cornea, and there is no mucous secretion. And with a slit lamp examination, we can see the inflammatory cells in the anterior chamber of the eye, which is in severe cases, they can form a white deposit called hypophyma. So polyarticular, it occurs in 20 to 30% of patients, most common in young girls. Here 4 or 5 or more joints are involved. Older children are affected. In oligoarticular, younger children. In polyarticular, it is older children. Here the characteristic finding will be the smaller joints are affected mostly, and also joint pain. Here it is out of proportion to joint swelling, which is quite opposite to oligoarticular, which I have told you earlier. Fever and malaise may be present. Subtypes of PJA will be RH factor negative PJA, where usual onset is younger age. Larger joints are involved usually, like knees, wrists, hips, and larger joints are involved. Small joints of hands and feet are less commonly involved, which is a characteristic finding of polyarticular, but here it is an exception that in RH factor negative polyarticular JA, small joints are less affected. Rheumatoid nodules are not seen, and it is of good less severity than Rh positive PJA. That means it has a good prognosis than positive PJA. PGIA means polyarticular juvenile idiopathic arthritis. The second subtype is Rh factor positive idiopathic arthritis, wherein the usual age of onset is late childhood or early adolescence. Here, arthritis is symmetrical, severe, and deforming type, so the prognosis is not good. Typically involves small joints of the hands like metacarpophalangeal joints, proximal interphalangeal joints, and wrist joint. There is a deformity called swan neck deformity of hands, wherein there is hyperextension of the proximal interphalangeal joints and flexion of the distal interphalangeal joints. So because it is because here RF factor is positive, there may be rheumatoid nodules present. Which is in RF negative, the rheumatoid nodules are absent. We have to remember, rheumatoid nodules are nothing but these are subcutaneous nodules which are found over pressure points and tendon sheets like elbows, heels, first metacarpophalangeal joints, extension surface of the fingers and knuckles. It is the only subtype of JAA which is similar phenotypically to adult rheumatoid arthritis. In this variety, in this subtype of polyarticular JAA, cervical spine and temporomandibular joint can be affected. Chronic TMJ involvement may affect the growth of bones around the joint and may cause micrognathia. ANA may be positive along with RF. Here you can see polyarticular arthritis. If you can see that there is swelling of all the proximal interphalangeal joints and there will be bony overgrowth. Common sites of rheumatoid arthritis, as I told you, rheumatoid nodules will be on the elbows, arms, first metacarpophalangeal joints, extensor surface of fingers, knuckles. You can see here. The third one is enthesitis related. Fourth one is the enthesitis related arthritis. This is mostly oligoarticular. It can be polyarticular, more common in boys. Characteristic joints involved are hips and sacroiliac joints. So, just to recollect, oligoarthritis, they will involve larger joints, polyarticular, smaller joints, and enthesitis related will be involving hips and sacroiliac joints, that is joints of the back. Many are HLA-B27 positive, which is a marker, a genetic marker predisposition, and if it is positive, the child may have ankylosing spondylitis and other sacroiliac sacroiliitis in the future. So many are HLA-B27 positive and may develop ankylosing spondylitis later as adults. Here there is also inflammation at the insertion of the tendons and ligaments, which is nothing but enthesitis. There will be pain, stiffness, and restriction of mobility of the back may be seen because joints of the back are more involved here. So back pain will be the presenting feature usually. There may be a family history of ankylosing spondylitis or low backache or psoriasis in these children. Here, one of the complications will be acute symptomatic iritis. In oligoarthritis, it is asymptomatic chronic iridocyclitis. Here it is acute symptomatic iridocyclitis, but it doesn't, and which doesn't progress to the chronic iridocyclitis. If it is a chronic iridocyclitis, the child will have a danger of getting blindness. Here it will not be there. So inflammation of the enthesis, as I told you, it is nothing but the attachment of the tendons or ligaments. So inflammation of enthesis plus arthritis, that is called enthesis related JAA, and it should have two of the six red, like inflammatory spinal pain, sacroiliac joint tenderness, family history of enthesitis related JAA, acute antiuveitis, HLA B27 positivity, polyarthritis or oligoarthritis in a boy greater than 8 years of age. So these six, out of these six, at least two should be there. Plus arthritis, plus inflammation of the enthesis. Psoriatic arthritis, that is nothing but arthritis along with psoriasis. Onset will be mid childhood. Affected joints are knees, ankle, distal interphalangeal joints. Important clue will be involvement of the interphalangeal joints along with tendon sheath, making the fingers appear diffusely swollen. Here there will be a diffusely swollen joints will be there, interphalangeal joints will be there, and arthritis may accompany or follow or precede the psoriasis. So swollen interphalangeal joints with history of psoriasis or with family history of psoriasis, we should suspect psoriatic arthritis. So chronic arthritis and definite psoriasis, it should be there, and it should have two of the following three rates. Like they should have this. That is an important point. Like dactylitis, which is nothing but finger or toe inflammation, onycholysis, that is nail pitting, and they should have family history of psoriasis. At least two of these three features, like dactylitis, onycholysis, and family history, of these three features, if the child is having two of the two features plus psoriasis plus arthritis, we should suspect psoriatic arthritis. So coming to the lab diagnosis, just so lab diagnosis only, it will be of only supplementary value, because clinically only we have to diagnose or suspect JAM. Lab diagnosis will help us in differential diagnosis part, and usually we call for CBC, wherein we can see anemia of chronic diseases, polymorphonuclear leukocytis and thrombocytis. The latter two, means like leukocytis and thrombocytosis with raised ESR, will be specific of systemic onset JAM. ESR is elevated, CRP is elevated. Both of these are surrogate markers of disease activity and are helpful in follow-up. Synovial fluid aspiration for microscopy and culture. This is indicated in children with monoarthritis to rule out septic arthritis. Serology for RF, ANA, and HLA-B27 genetic markers, and plain X-ray and ultrasound. They may show effusion of the joint. Plain X-ray and ultrasound. Sorry, here it's written as ultrasound abdomen. I'm sorry, it's ultrasound of the joint. Plain X-ray of the end, ultrasound of the joint. They may show effusion. X-ray can be repeated for assessment of the erosion. 2D echo to rule out pericardial involvement, which is usually seen in systemic onset type. Slit lamp examination for a female child with oligoarticular presentation with DNA positive. We should ask for slit lamp examination to rule out iridocyclosis or uveitis. Bone marrow aspiration to rule out ALL. So up to lab, just to recollect, juvenile idiopathic arthritis is nothing but arthritis of more than one joint with duration of at least 6 weeks and with onset of less than 16 years of age. And types, and the pathophysiology is autoimmune. It's an autoimmune disease with etiology as genetic and environmental factors playing as etiological agents, and basing on the type of type and basing on the number of joints involved during the first 6 months of onset of disease, it is subclassified as oligoarticular, wherein 5 or less than 5 joints are involved; polyarticular, wherein 5 or more than 5 joints are involved; systemic onset, wherein JA features, wherein arthritis plus systemic features like fever, rash, pleuritis or pericarditis, and hepatosplenomegaly, lymphadenopathy may be present, and enthesitis related arthritis, wherein inflammation of the enthesis plus arthritis should be there, and with the present with in wherein emphasize wherein joints of the back are frequently involved in enthesis related arthritis. The last but not least is psoriatic arthritis, wherein there should be psoriasis plus arthritis plus two of the three features like dactylitis, onycholysis, and families. So coming to the lab diagnosis, because it is a clinical diagnosis, but supplement for supplementary evidences, we should ask for CBC, wherein we can find anemia of chronic disease, leukocytosis, thrombocytosis, raised ESR and CRP. Synovial fluid culture, we can differentiate whether it is a septic arthritis or JIA. Serology for RF, ANA, and HLA-B27, plain X-ray and ultrasound of the joint, where they may show effusions. And if there is any erosion, also we can find in later X-rays. 2D echo for pericardial involvement, slit examination, slit lamp examination for to rule out chronic iridocyclitis, and bone marrow aspiration to rule out ALL. So coming to management, there is a medical management wherein we NSAIDs are one of the medical. Coming to medical management, there will be NSAIDs, disease modifying anti-rheumatic drugs, steroids, and biological agents are present. First, we will start with NSAIDs. Previously, it was the first line of drug, but now it is replaced by DMARDs, that is disease modifying anti-rheumatic drugs. But if the presentation, for your knowledge, if the presentation is of polyarticular type, we should first start with DMARDs, I mean disease modifying anti-rheumatic diseases, followed by NSAIDs. And let's say NSAIDs does not give any cure, they only reduce pain and stiffness. So coming to NSAIDs, the most commonly used drugs are naproxen and ibuprofen, followed by diclofenac, indomethacin, and piroxicam. Naproxen, it is given at a dose of 15 to 20 mg per kg per day, divided twice daily. Ibuprofen is 35 to 45 mg per kg per day, divided 4 times per day divided. Indomethacin, which is usually given for enthesitis related JAK, it is given in a dose of 1 to 2 mg per kg per day, thrice daily. Diclofenac 2 to 3 mg per kg per day. Of these, and piroxicam 0.3 to 0.6. Of these 5, naproxen is the most commonly used and safest NSAID. This is an important point. Response is not immediate. It will take minimum of 3 to 4 weeks. So you should counsel the parents that it will take some time. In the meantime, what should we do? In the meantime, we should give rest to the joint, limit the move, not complete limitation, but limitation of movements of the joints affected, and adequate rest. So response will take at least 3 to 4 weeks, and so minimum 4 to 6 week treatment is required to switch to another NSAID. Of all preferred NSAID, which I have already told you, is naproxen is the preferred drug. Remember, this is not the first line of treatment as per recent guidelines, but in OPGI, which you usually follow, NSAIDs are given as the first line of drug. But to make it simple for you, though we use for NSAID, and though we use NSAIDs for other types, but if the presentation is polyarticular type, we should, and or systemic onset type, we should first start with disease modifying anti-rheumatic disease. That will be the first line of drug for polyarticular and systemic onset JA. For the other forms, we can start with NSAID. We can add on DMARDs if there is no response. So management, second line of drug, second will be disease modifying anti-rheumatic drugs. These are the first line of drugs for effective management of JA and for better result to prevent erosions like that. Commonly used AMERDs are methotrexate, which is the best preferred because it is the safest drug for children and they better tolerate, and children they tolerate better than the adults. Sulfasalazine, leflunomide, and hydroxychloroquine. These are the disease modifying anti-rheumatic drugs. In DMARDs also there will be two forms, like which we call synthetic and biological. Synthetic is methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine. In biological, which I'll be telling you later, etanercept, infliximab, all these they come under biological agents. So methotrexate, it is given as a weekly dose of 15 to 20 mg per square meter, or 0.15 to 0.5 mg per kg, either given subcutaneously or orally. Orally also, there will be a parental form that suspension can be given orally. Once the child is in remission, the drug can be tapered to a minimum effective dose, but this will take some months for complete remission, so and can be stopped. The most common side effect of methotrexate is hepatic fibrosis. So periodic liver function test is necessary. In DMARDS, the most commonly and used and the safest drug is methotrexate. Coming to corticosteroids, they are used in the presence of pericarditis, pleuritis, or idiopsychitis. The corticosteroids are given in the form of intra-articular glucocorticoids or systemic glucocorticoids. Intra-articular glucocorticoids, usually triamcinolone is used, and it is used in child with oligoarthritis, which is who are not responding to NSAIDs. Systemic glucocorticoids, by name itself, we can understand that if there is any rapidly progressive or systemic presentation, systemic onset JA, we can give systemic glucocorticoid. Usually, prednisolone and methylprednisolone are used. The dosage of prednisolone is 1 to 2 mg per kg per day, and if it is methylprednisolone, it is 10 to 30 mg per kg per day. This is usually systemic glucocorticoids are usually given for unremitting arthritis, systemic manifestations, and rapidly progressive disease. Prednisolone is used as a bridge therapy. Bridge therapy means, suppose if you start methotrexate, for it to show effect, it may take 1 to 2 weeks. So in the meantime, to prednisolone also can be started as a bridge therapy, so that because of the inflammation, you will not be having pain, or you will get some sort of relief from the pain. So it will be used as a bridge therapy. I think you got me. Or bridge therapy is nothing but, suppose if you start with methotrexate, and for methotrexate to act, it will take some weeks. In the meantime, to get some relief of pain, or to increase or improve the quality of joint movements, we'll add steroid as a bridge therapy. Once the methotrexate starts showing its effect, we can taper the prednisolone dose. Coming to biological agents, which is the newest modality. Here, actually, I would like to tell you, if you go to the pathophysiology, the most important problem here is there will be, it is an autoimmune disease wherein inflammatory mediators, they get activated, and these mediators, they attack these inflammatory mediators are nothing but TNF alpha, IL beta, IL-1 beta, IL-6, all these they attack the host tissues, thinking that they are foreign antigens. So instead of giving these methotrexate NSAIDs, if we can directly act upon those inflammatory mediators or cytokines, we can stop the progression, or to some extent we can give maximum relief with these biological agents. Usually used biological, I think you got me. So these are directed against the cytokines and pro-inflammatory mediators. And T cell activation. These mediators are released only after the activation of T cells within, which I told you that it is a cell mediated immunity that is causing the JIA. So cell mediated immunity means it is mediated by T cells. So here we target T cells or the inflammatory mediators or cytokines. So biological agents, anakinra, wherein it is an IL-1 receptor antagonist. Tocilizumab, it is an antibody to IL-6 receptor. Infliximab, it is an antibody to TNF alpha. These are all inflammatory mediators and cytokines. Etanercept, which is the most commonly and best used biological agent, is etanercept in a dosage of 0.4 mg per kg twice weekly. It is an inhibitor of recombinant soluble TNF receptor, wherein it attacks directly the TNF receptors. Abatacept, which is an inhibitor of T cell activation. So, in short, because it is a cell mediated immunity, we need T cell there should be T cell activation. When T cell gets activated, it activates a B cell, that is a macrophages, which release inflammatory mediators like TNF alpha, IL-6, IL-1 beta, all these things. These inflammatory mediators, they attack the synovium and the osteoclasts. So we are breaking this sequence either by blocking the T cell activation or deactivating the inflammatory mediators. That is the main role of these biological agents. So etanercept is used in children with polyarthritis not responding to methotrexate. It is most commonly used drug is etanercept, and infliximab is used in adults with spondyloarthropathy, that is ankylosing spondylitis and sacroiliitis. Tocilizumab and anakinra is used in children with SJIA, that is systemic onset JIA. Newer modalities are autologous stem cell transplants, which is seen in refractory, progressive, and severe JAA. So, in short, if you go for treatment, if it is an oligoarticular type, we will start with NSAID with intra-articular steroids. If it is polyarticular type, that is more than 5 joints involved, we will start with DMARD first, followed by NSAIDs or bridge dose of steroid, that is prednisolone. DMRD most commonly used, as you know, as I've told you, that is methotrexate. Systemic onset type, NSAID plus systemic steroid, that is nothing but prednisolone or methylprednisolone. Supportive therapy, physiotherapy is the most important supportive therapy in the long-term management and prevention of deformities, because physiotherapy helps in relieving pain, maintenance of posture, and joint mobility. It also improves the periarticular muscle strength and also prevents the contractures. During acute stage, before the NSAIDs or whatever DMARDs, they show their effect, what we have to do is we have to give rest and application of it to the joint. And once the pain decreases, active movements from minimal to full range can be done to prevent contact. These movements are must to prevent contractures. Splints during sleep. Child should rest on hard mattresses and in prone position for some time each day to prevent contractures of hip and knee. Swimming is the best exercise, as the buoyancy of water will allow joint mobility with less effort. So in short, the management will be for oligoarthritis, NSAID plus intraarticular glucocorticoids. For polyarticular, it will be DMARDs plus bridge dose of steroids and plus or minus NSAID. In the sense, if required, NSAIDs also can be added. If it is systemic onset, NSAIDs plus systemic steroids, all these plus supporting therapy. Supporting therapy means supporting therapy is only to relieve pain and to prevent contractures. Now coming to complications. Complications will be anemia because of arthritis and blood loss due to NSAIDs, chronic iridocyclitis, which I told you, it should be seen. It will be seen in girls with less than 6 years of age with oligoarthritis and ANA positivity. Treatment with the local steroid instillation, mydriatic eye drops, and methotrexate. Neck stiffness if the cervical spine is involved, leading to it may lead to torticollis. If the temporomandibular joint is involved, it may lead to micrognathia. So anemia, chronic iridocyclitis, neck stiffness, torticollis, micrognathia. The important one will be growth failure or limb length discrepancies and joint contractions. They will be seen in long-standing diseases. The the most uh, potentially lethal complication will be macrophage activation syndrome, wherein the macrophages, they attack the blood cells of the bone marrow, leading to pancytopenia, and the cause of death will be the features because will be the complications due to pancytopenia. The most commonly affected type is children with systemic onset JAA are more prone to develop this complication. Clinical features will be unremitting fever because of pancytopenia. There will be recurrent attacks of fevers, sudden onset of icterus, bleeding tendency. As I told you, there will be, because the macrophages here will be attacking the blood cells in the bone marrow. That will lead to pancytopenia. So there may be bleeding, icterus, unremitting fevers. And if you go to lab diagnosis, it will be leukopenia, thrombocytopenia, elevated triglyceride, raised ferritin levels, hypofibrinogenemia. Treatment is IV methylprednisolone. Prognosis, as I told you, oligoarticular has a good prognosis and is also most common form of JAA. Enthesitis-related arthritis can develop spondylitis and sacroiliitis if they are HLA positive, HLA-B27 positive later in their adults. Later in their adulthood, children with RF positive arthritis, they have a disease pattern phenotypically similar to adult type of arthritis, and it has a very bad prognosis. It has a bad prognosis in the form of, because it may cause erosion and deforming arthritis. Prognosis is better for seronegative polyarticular JA. So in polyarticular JA, if it is RF positive, prognosis is bad. If it is RS negative, its prognosis is good. In systemic onset JA, 50% will have residual joint involvement and remaining will have progressive arthritis. So untreated patients will develop flexion contractures of hip, knees and elbows, which are and may lead to permanent disability. So differential diagnosis, which is important. Infective septic arthritis. When should we suspect septic arthritis? In septic arthritis, there will be an excruciating pain with erythema over the joint. It will be asymmetrical presentation, and child will be looking very toxic with systemic features like fever, malaise, anorexia, and which all these are not seen in JAA. And as I told you, JAA nothing but less than 6 weeks duration, minimum 6 weeks of duration, less than 16 years of onset. At least one joint should be involved. Here, second one is osteomyelitis, wherein there will not be pain in the joint, pain will be at the metaphysis region. Tuberculous arthritis, it is a hypersensitivity reaction to the organism. So it will be usually symmetric or asymmetric. It can be symmetric or asymmetric, but it's an hypersensitivity reaction. That means there will not be any excruciating pain or joint swelling like that. Tuberculous workup will help will aid us in differentiating from this JAA. Rheumatic fever, it is, as I told you, JAA is nothing but it's a chronic presentation, and rheumatic fever is an acute presentation. Here there will be migrating type of arthritis or fleeting type of arthritis involving only larger joints. But in JAA, it will be smaller and larger joints will get involved. No fleeting type of nature. It's a chronic type of presentation. There can be erythema marginatum, as per Jones criteria. Erythema marginatum, severe carditis, which is not seen in JAA. Reactive arthritis, it usually follows some GI infection or genitourinary infection caused by the Yersinia, Shigella, Chlamydia, etc. Or it is a peripheral. Reactive arthritis is a peripheral arthritis, asymmetric arthritis involving only the lower limbs. Transient arthritis, it usually follows upper respiratory infection. It usually involves pain in the hip region, thighs and knee region, and it's a self-limiting disorder. Splintage of the limb is enough. There is no specific duration or the period of disease. Where in JA there will be 6 weeks of duration and less than 16 years of onset. Here there is no such thing in transient arthritis. SLE, they may present with malar rash. There will be hematological manifestations. There will be nephritis, which will not be seen in JAA. In acute lymphoblastic leukemia, we have to go for bone marrow aspiration to differentiate between both. Hematological, most commonly hemophilia. For male child will be seen, hemarthrosis will be there, and the bleeding manifestations, sorry, in what do you call coagulation studies. By coagulation studies, we can differentiate between JA and hemophilia. Sickle cell, already with peripheral smear, we'll be seeing sickle cells, and there will be history of repeated attacks of joint pains, that is crisis syndrome. Mm, and there will be icterus. Thank you.